Welcome to Intercepting Sleep Disordered Breathing. My name is Dr. Ben Miraglia. Regarding HIPAA copyright violations for any material used in distribution without permission, no photos or video recording may be taken or distributed of cases and/or slides from today's presentation. Replication of patient information in slides is prohibited. Any use of this material without consent from Dr. Ben Miraglia and Lauren Gates is a violation of copyright and HIPAA laws. Well, today we're going to dive into, how did we get here, and how did we get where we are with the levels of childhood sleep disorder breathing that we see, and then of course adult obstructive sleep apnea that's out there. And the idea is that there's a fair amount of childhood sleep disordered breathing, and an unhealthy child will grow up to be an unhealthy adult. So there's a fair chance that if childhood sleep disorder breathing is left to its own devices, all of a sudden what happens is we should expect that child to grow up and have the opportunity to end up in the adult obstructive sleep apnea category. While there are children in the OSA category, that's a very small group. The research shows somewhere between 3 to 5% maybe of children have OSA, but a significantly larger group of children have sleep disordered breathing. And then of course, if it's left untreated, how will that child grow up? The sleep disordered breathing in children is an unhealthy thing, and certainly we're here to intervene. So we'll spend our time walking through and building you a nice puzzle on the relationship of childhood sleep disorder breathing, adult obstructive sleep apnea, and then what our role will be once we understand, how we got here. So as we get started, we think about the children, and so all of us come across children at various stages of the day, the week, the month, and the year, and we would recognize that there are a lot of children with symptoms. And the symptom list begins with the ADHD, but it also includes asthma, upper respiratory infections, ear infections or ear tubes, bedwetting, nightmares, night terrors, learning disabilities, clenching and grinding of the teeth, restless sleep waking often, small or delayed growth, anxiety or depression, daytime sleepiness, overweight, night sweats, gastrointestinal distress or reflux, emotional instability, mouth breathing. And that list is a beginning of the symptom lists that are all related to sleep disordered breathing. Excuse me. So in order to begin our puzzle, we want to talk about the most common malocclusion. And so we're going to work our way from malocclusion to the sleep disordered breathing. So in our world, we get to see a lot of malocclusion, and the idea is that crowding is the most common malocclusion. In the general categories, we would have crowded malocclusions or spaced malocclusions, and crowding exists a whole lot more than spacing. When we think about the crowding, we would recognize that there are causes of crowded malocclusion. And so the idea behind a crowded malocclusion is that it begins with an improper arch form. And we would recognize this as a V shape or omega shape arch form. And then of course, the improper arch form combined with an improper arch width deliver our crowded teeth. In other words, with an improper arch form and an improper arch width, we have an underdeveloped foundation, and the underdeveloped foundation doesn't supply the space for the teeth to fit in perfectly, so we end up with a crowded malocclusion. So an improper versus a proper arch form, let's take a look at the difference here, because we see the V shape on the left side of the screen, and that V-shaped arch form is improper, and an improper arch form delivers your crowded malocclusion, but it also delivers a lot of other issues beyond just crowded teeth. On the right side of the screen, we have an example of what a proper arch form looks like, and it's a beautiful dome, and it has, shape that is consistent and smooth right from, one second molar to the other. From tooth 2 to tooth 15, we have a very nice shape of the arch. This is a proper arch form. And as we build our puzzle, we'll recognize that it becomes less about the teeth and more about the foundation. The biggest difference between the pictures isn't really the teeth, it's the vault. And so as the maxilla is more narrow, with its improper arch form, the vault might be higher. And so all of a sudden we have a difference in the vault. And the vault of the maxilla, the palate area, is really the home for the tongue. And so we start to explore Could the difference in the shape and size of the vault affect the tongue? And is there a relationship there to then the breathing? So our goal is to develop a proper arch form, and if we don't, we're probably well on our way to becoming unhealthy. So as we begin to build the puzzle, we recognize that an improper arch form and width are the results of inadequate development of the maxilla and, of course, the mandible, because it's also in the picture. So improper arch form and width are the results of inadequate development of the maxilla and mandible. They're not growing appropriately. Now, an underdeveloped maxilla causes crowding of the teeth, but an underdeveloped maxilla also will have an adverse effect on the position of the mandible. The mandible is the free piece, and it can move around. We can move our jaw. The lower jaw can move backward, forward, open, closed, right, left. But the mandible has a landing spot. Well, when the mandible closes, its landing spot is determined by where is the maxilla and how has it grown. So basically, the maxilla has an adverse effect on the mandible's position, means if the maxilla did not grow to its full potential, then the mandible is landing in the wrong spot. The only opportunity for a mandible to close and land appropriately where it should be is if the maxilla grew to its full potential. So anyone with an underdeveloped maxilla has a mandible in the wrong place when they close. So growth, when we're thinking about growth, normal or ideal growth is wider, forward, and a little bit downward. So we would expect the maxilla and the mandible over time to grow wider, forward, with a little bit of a downward direction. Abnormal growth is any combination of narrow, backward, but it does include the downward component, but we get excess downward growth sometimes. So if we're not growing wide, we're narrow. If we don't grow forward, we're backward, and our fancy word in dentistry for that is retruded or retrusive or retrognathic. We have all kinds of wonderful words for a lack of forward growth. But the downward component does pick up a little bit, and in some cases we get excess downward growth. The key is not having the wide or forward, and instead having the narrow and backward. Most of the abnormal growth that we would see is underdevelopment. Now, there is such a thing as normal or ideal growth and development, and we want to just take a look at what that would look like so we have a perspective on where we should be. And so when we want to call someone normal or ideal growing patterns, we would look at a 5-year-old and look for certain characteristics. A 5-year-old that has a significant gap between every single primary tooth and has a full view of the lower teeth when they're closed is well on their way with normal or ideal growing, but these aren't the only characteristics. So the first two things we'd be looking for: a significant gap between all of the teeth and a full view of the bottom teeth when the child closes. Those are the first two steps or criteria for normal and ideal growth in primary dentition, but then it comes with something else underneath. And the idea here, it would be, if we take our cephalometric x-ray, or a lateral head plate, so to speak, we can recognize where the structures are. The nostril is easy to see. And if the nostril is easy to see, we can follow where the air would flow from the nostril all the way through the tube that leads to the trachea. And so that tube, or that roadway here, is very wide or large. And so the idea is, all of a sudden, we would recognize that this child, when their mouth is closed and they're doing their nasal breathing, the air has a beautiful passageway to go through. And that passageway, we could describe it as maybe the size of a garden hose. And so this is a very nice large tube, the size of a garden hose. What we see on this film is the patient is growing forward. If we have forward growth of the maxilla and the mandible, the tube will be larger. And if we have a lack of forward growth of the maxilla and mandible, that tube could be smaller. So here, this child makes the criteria, so to speak, for normal or ideal growth and development in the maxilla and mandible in the primary dentition stage. They have a full gap between every single primary tooth. They have a full view of the bottom teeth when they're closing, and the growth is forward, in that with our cephalometric x-ray, we can see a large tube behind the jaws for the air to flow. Now, this is something that we see rarely. And so this normally or ideally growing and developing 5-year-old shows up in our practice about 1 or 2 times in a few hundred kids. So when we look at several hundred children and we see these credentials just once or twice, we take a lot of photos so that we would have a record of a child that's actually growing and developing on time and on pace. And meanwhile, we do refer to it as an endangered species. It's almost like finding a unicorn to find a child that has those three characteristics. Now, that endangered species, one day, that 5-year-old has the opportunity to grow all the way to 12. Now, without intervention, without any type of orthodontics or appliances or expanders, no intervention whatsoever, that 5-year-old who was on the right track will make it to 12. And here we are at age 12 with a proper arch form and a beautiful arch width and a very nicely developed palatal space for the tongue, very minimal to no crowding. This patient here with their normal and ideal growth and development has what we would identify as the angle classification, right? Class 1 occlusion. And that occlusion has all the credentials of healthy and stable and functional and comfortable and, of course, aesthetically appealing. This child has all of their teeth landing about where they belong. And then we think about in the 12 to 13-year-old age range, how many children do we meet at age 12 to 13 and without having any intervention, all of their teeth are pretty much where they belong. It resembles our typodont model. That's another rare find. 12 to 13-year-olds typically show, the majority of them will have the crowded malocclusion, and meanwhile head into that 12 to 15-year-old age range of what we would call braces and or other orthodontic techniques. But the idea is it's rare to find a 12-year-old on track where they belong. Now, if the foundation has grown beautifully, which the maxilla and mandible here have grown appropriately so the teeth came in where they belong, then all of a sudden we see more. And we start thinking about, all right, what about next questions? Why? Why are the maxilla and mandible underdeveloped? And so that's going to bring us to our next level, which is, why are the maxilla and mandible underdeveloped? We want an answer to that. And all of a sudden, for that answer, we start looking at anthropology research. And there are researchers like Dr. Robert Corricini and others. He's not the only one. But not only is he an anthropologist, but he has 30 plus years, almost 40 years of research on malocclusion anthropology. So prior to meeting him, I had no idea that there was such a thing as a malocclusion anthropologist. But meanwhile, he has dedicated almost 40 years of research to malocclusion anthropology. And of course, with 7 books and hundreds of journals, he has done fossil studies, population studies, animal testing, genetics and or twin studies to learn how or where does malocclusion come from. So it culminates in his book. In his book here, I would put as a high recommendation for anyone in the dental profession. The title of the book is How Anthropology Informs the Orthodontic Diagnosis of Malocclusion's Causes. How Anthropology Informs the Orthodontic Diagnosis of Malocclusion's Causes. In other words, where do we get malocclusion from? So what we learn from Dr. Corricini and others, their research shows that prior to 400 years ago, there's little to no malocclusion in the human race on planet Earth. And the skulls that are studied prior to 400 years ago have very nice full development of the maxilla and mandible, and mostly have 32 teeth represented, very similar to what we would recognize and call our typodont model. So 32 teeth in place, a standard kind of characteristic alignment of teeth that is a beautiful arch form and width, and little to no evidence of malocclusion prior to 400 years ago. So what we learn from anthropologists as they study global populations, they travel the world to study isolated and rural people. And while they're studying isolated and rural people, they recognize that the breastfeeding is followed by a gritty, hard diet. They recognize the consistency of the food is different in the early years. As they follow these people, they learn that there's little to no evidence of malocclusion, but there's also little to no evidence of inflammatory or degenerative diseases in these cultures. There's little to no variation. The jaw growth is similar, it's full. The 32 teeth are present, and the bites are very consistent, so they have little to no variation in these populations. Obviously, they get to study these populations as they become exposed to Western cultures, and this is what triggers the thought process and then the ultimate conclusions. As these populations become exposed to Western cultures, they notice one of the first things that happens is trade. And the trade for food is one of the first things that happens as cultures become, let's say, westernized or industrialized. But the trade for food is significant because the Western or industrial influenced culture has a softer diet. And these isolated or natural or primitive or rural or anything we would describe them being protected from industrial or Western living has a very hard, gritty diet, even at a young age. So here comes the difference. What it does is it all of a sudden, it sends the anthropology world into animal studies, which involve hard and soft diets. So they take different animal groups while they're young and developing, and what they do is they just divide them in half. They give half of the group its normal, natural habitat diet. But then what they do with the other half of the group is they give them a soft and or mushy, industrial, westernized type of consistency. Basically, they're getting a Gerber. And so now you have a hard, soft diet study in place. What these studies do is they track the growth and development over time in these groups. The soft diet animals have the same pattern of growth and development, and it's different. In the soft diet animals, they have smaller body mass, less dense bone, smaller, weaker oral musculature. And once you have smaller, weaker oral musculature, because it's not being used with a more of a soft or liquid diet, if the smaller, weaker oral musculature exists, then what happens is we end up with a narrower maxilla, a smaller mandible, a thinner alveolus, and smaller condyles. The lack of the muscle strength produces the lack of the bone growth, and the opposite is true. In other words, in a human being, form follows function, and bone yields to muscle. So when the muscles of mastication are used appropriately, we get the bone growth. So when breastfeeding is followed by a gritty, hard diet early, the musculature develops, and because the musculature develops, it influences the bone growth. It provides the bone growth. But when we have a early soft diet, all of a sudden then we get smaller, weaker muscles, and then the muscles do not influence the bone. So the bone does not grow as much, and we end up with a narrower maxilla, smaller mandible, thinner alveolus, and smaller condyles as the result. Now, with broken isolation, anthropology research can study when a culture was so-called experiencing broken isolation, meaning having Western influence, and they can track that culture to determine, okay, what is the rate of malocclusion? How fast does it come on? And what they learn is that within the first generation, after exposure to prepared, processed, and preserved foods, the malocclusion rate becomes 50%. So half of the population develops a malocclusion after the exposure to prepared, processed, and preserved foods. But by the second generation, as the softer diet becomes more of the diet, all of a sudden, the second generation, the rate rises to 70%. By the third generation, we get to 85%. And by the fourth generation, about 90%. So we're breaking 90% malocclusion rates 4 generations into an early soft diet. 4 generations, a generation could be anywhere from 20 to 25 years. And so in 4 generations, which is less than 100 years, you have a better than 90% malocclusion rate in the population. Now the variation also increases, which is simple for us to understand in our fancy dental terms. Well, variation from a typodont occlusion starts to include the things we would call cross bites, excess overbite, open bite, excess overjet, negative overjet. The cross bite could be the right side, the left side, or both. The cross bite could be the anterior. Class 2 malocclusions, class 3 malocclusions. All of a sudden, the variation of how the jaws and teeth relate increases. So we see a whole list of different types of malocclusions, those that have class 1 on the right side, but class 2 on the left side, and the opposite of that as well. So within 100 years, cultures that become industrial or Western influenced have malocclusion rates above 90%. So what we would want to consider there is that in America today, the children are 6th and seventh generation post-industrial living. So we would expect a much higher rate, maybe closer to 100. So you'd have a high 90 percentile rate of malocclusion or underdevelopment in children today, thanks to that most common early soft diet. Lack of muscle use and development, delivering the lack of bone growth. It accounts for why we would see very few kids with primary teeth meeting the characteristics of normal or ideal growth and development. So Dr. Corricini, in his book, How Anthropology Informs the Orthodontic Diagnosis of Malocclusion's Causes, has his conclusion statement summed up very nicely. Dietary consistency and toughness promote proper bone growth and proper permanent tooth eruption, bringing about ideal occlusion. When non-resistant processed foods become ubiquitous after industrialization, and the erupting and cuspal coordination of teeth lose the critical pathfinder influence of vigorous masticatory pressures, malocclusion shows a rapid rise. Now, of course, that anthropology research leads us to a next question. What are the results of having an underdeveloped maxilla and mandible? Is it just crowded teeth and a malocclusion of some sort, or could there be more to that list? And so we're going to check our anatomy for that answer. So here we have the nice picture of the skull. We want to refresh our memory and the maxilla. Of course, the maxilla is holding our set of upper teeth in place, but the maxilla takes up a lot more than just what's holding in our upper teeth. If we remember the maxilla, we look in the mouth and we see the palate, but the palate is also the floor of the nose. So the floor of the nose, or the floor of the nasal chamber, is the maxilla. The maxilla also makes up the lateral walls of the nasal chamber. So when we see that skull and we look in the center, there's a triangle. That triangle is the nasal chamber. That's where we're going to be breathing through our nose and supplying ourselves with air. So the body's number one need is oxygen, or air. And so the idea there is the size of that triangle would be dependent on how the maxilla is growing. The maxilla that grows fully wide and forward ends up with a big open triangle. The maxilla that grows really wide has that shallow or low palate. So that's a fully open triangle, and then the air passes through nicely. But the maxilla that is narrow has several complications from the narrow or lack of development. A narrow maxilla comes with a vaulted palate. As the maxilla is narrow, the vault rises. It's kind of a collapsing mechanism. So if the maxilla is narrow, the vault rises. But as the vault is rising, we're losing space in the nasal chamber. So our nasal cavity is smaller with a narrow, vaulted maxilla. But of course, the maxilla makes up the lateral walls of the nasal chamber. So a narrow maxilla, it acts like a compactor. The lateral walls of the maxilla are coming together or closing. So we have the floor of the nasal chamber rising, that's the vault effect, and we have the lateral walls coming together. So the entire triangle is collapsing on us. And it doesn't stop there, it gets worse one more step. With the rise of the floor, or of course the vault of the palate, comes the deviation of the septum. In the center of the nasal chamber, we have a little wall in there, and that septum remains straight if the maxilla grows to its full size and potential. But if the vault is going to rise, when the floor of the nasal chamber is rising, the septum becomes deviated to one side or the other. A deviated septum compromises the airflow in that side's chamber even worse. So when we think about having a deviated septum, we like to put perspective on what's happening. Because the deviated septum is caused by the lack of growth and development in the maxilla, the vault rising, of course, we have a smaller nasal cavity with a deviated septum. So it's appropriate perspective to think about when we have a deviated septum, we have one nostril that has poor airflow and the other nostril has worse. So the nostril with the deviated septum, the airflow is worse, but the other nostril, it doesn't make it good, that's poor. We have an entire chamber that's smaller, but one side's worse than the other. So poor airflow on one side and worse on the other. But this is just the anterior view. The compromised in the growth of the maxilla delivers this nasal cavity that is smaller and will compromise that airflow. But we have to turn our patient to the side to look at a profile view and talk about growth forward. If the maxilla is growing forward, well, we would see more color here. So the little color regions are where the air would be flowing. So we've got the nasopharynx, the oropharynx, and the laryngopharynx. If the maxilla grows forward, we would have more color. With lack of forward growth, we would have less color. And now we can talk about the mandible. The mandible, again, its position is affected by the maxillary growth. So what we know, thanks to the angle classification of class 1, 2, and 3, if the maxilla is underdeveloped, the mandible remains behind the maxilla in every class 1 and 2 patient. Only a class 3 patient has the mandible in front of the maxilla. So class 1 and 2 makes up the most significant percentage. Class 3 is only a few percent of the population. So when we think about an underdeveloped maxilla, the class 1 and class 2 population have a mandible that is trapped back behind it. And of course, the mandible is holding the tongue, and a tongue that is backward interferes with the airflow. So all of a sudden, with a mandible that is behind its position, or behind its ideal position, comes a tongue that is behind its ideal position. And we have words to describe that: posterior displacement of the tongue. So the underdeveloped maxilla, if it doesn't gain its forward growth, it's back, and so is the mandible, which is holding the tongue. And that creates another issue for us. So as we look at our anatomy with regards to underdeveloped maxilla and mandible positions, we start to connect the dots, and we recognize that the crowded teeth in the malocclusion, while those are unhealthy, they're also symptoms. Probably the most pressing item that the child has is related to the airflow. When the maxilla and mandible do not grow to their full potential, the result is a child with a compromised airway. The lack of growth in the maxilla and the mandible introduces nasal airflow resistance. Nasal airflow resistance is the first step in becoming unhealthy. So when we take a look at a 10-year-old, we could take our cephalometric x-ray, our lateral head plate, so to speak, and we could identify where the nostril is. The nostril is going to draw the air in, and it's going to follow that chamber, that tube, all the way to the trachea. Well, this airway, so to speak, and this is just a ceph or lateral head plate, it's 2 dimensions, but it does show wide. So this airway is a garden hose. That's a very nice airway to have. That's a significant size for air to flow. And this child is 10 years old with normal or ideal growth and development at this point. We meet a lot of 10-year-olds, though, and more of them show up like this, where when we look at the nostril and follow the airflow, all of a sudden, it's like an hourglass or a sand timer. It collapses in the middle. It's narrow in the middle. Then it opens up again at the trachea as we go through. This is a very small airway. This child has not grown wider or forward. This particular picture, our ceph, shows our forward or lack of forward growth. The idea is when we compare these two children, they're both 10 years old. One is growing appropriately, fully forward. The other is not. They're both class 1 in their bites. So as far as the angle classification goes, the teeth connect in a class 1 relationship for both kids. However, one child is perfectly healthy and has no symptom list or medical history during their first 10 years of life. The other child, the medical symptoms began right after birth and continued all the way to age 10. And at this point, it includes 4 different medications to manage symptoms, all related to sleep disordered breathing. How do those children look as far as their growth and development? Well, on the left side of the screen, we have someone who's grown fully forward and wide and has a jawline, has their lips well ahead of their eyes, has the full definition of a cheek bone and the jawline and a distinct head and neck. Whereas the child on the right, from the eyes down to the lips is almost straight. The lips are not grown ahead of the eyes. All of a sudden, there is no jawline. There's no chin. The neck begins to compensate and slide forward and out. And basically what we have is more of a funnel shape or a blending or melting of the cheek through the jaw, through the neck. And the head and neck are no longer a distinct difference. They're almost one in the same structure. So what we would see on the inside would be reflective of the outside, and what we see on the outside is reflective of what's on the inside. Again, one of these children is healthy with no history in medical symptoms. The other child has a medical symptom list that begins after birth and continues all the way to 10 years old, culminating in medications until we have the opportunity to treat him. So it brings us to sleep disordered breathing. That compromised airway is going to bring us to sleep disordered breathing. So what our anthropology research taught us is that an early soft diet delivers weaker muscles. The weaker muscles don't influence the bone to grow. If the bone doesn't grow, well, we end up with what we see as crowded teeth in a bad bite, that crowded tooth malocclusion. But without the bone growth, what we have is a compromised airway. We've got a lack of space for the air to flow, and it introduces nasal airflow resistance. Now, sleep disorder breathing is a generic title, and it could be anything from mouth breathing, snoring, upper airway resistance syndromes, all the way to the end result of obstructive sleep apnea. So we refer to that pattern of breathing that is not normal, silent, and invisible nasal breathing as sleep disorder breathing until we have some sort of sleep study or credentials that give a specific diagnosis as to what is going on. So sleep disorder breathing is the topic. But what it results in is a decrease in nasal breathing. The nasal airflow resistance delivers a compensation. With the lack of anatomy to have beautiful airflow, that underdeveloped jaw structure influences the air in that all of a sudden what we get is nasal airflow resistance. And so with nasal airflow resistance, the body recognizes that's not enough air and that breathing isn't so good. So the first step in altering the breathing pattern of normal nasal breathing, which human beings are obligate nasal breathers, the first step is mouth breathing. So the body will open the mouth and allow air to come in through the mouth. But the decrease in nasal breathing changes the body. All of a sudden, we have an altered biochemistry and physiology during sleep. The compensation pattern that goes on to improve the breathing will change the biochemistry and physiology during sleep. And the end result is that we're going to experience sleep fragmentation or a disruption of the reparative sleep cycle, which will deliver an unhealthy child. And an unhealthy child will grow up to be an unhealthy adult. These things tend to get worse over time, not better. So if we take a look at a child age 3, we'll begin here. So a child age 3 comes in and we'll recognize in a moment there'll be maxillary deficiency. The child has a history with sleep disorder breathing. Some of the early symptoms are there's trouble falling asleep, we're waking at night, and of course at 3 we'll be in primary dentition. So we'll take a look at someone who's 3. So here we have a child who has maxillary deficiency. It looks like the lower jaw is prominent or the chin is prominent. The child is fully closed and giving a little smile. It almost looks like the edentulous patient when they close. The lack of maxillary growth and development can look like almost like having a denture if you're really underdeveloped. But this child has the mandible escaping in front of that maxilla that is deficient. So with severe maxillary deficiency, the child is overclosed and forward in the mandible position. But when we think about the mandible specifically, while it may be forward of the maxilla, because the maxilla is very deficient, we have to look at a little bit more, like the neck. So what we would see in this child is the creased lip already at the corner, and the compensation of the neck popping down under the chin. When the neck begins to compensate here, all of a sudden, that's an indication that the mandible is too far back. The further back the mandible is located, the more the chin, under the chin, starts to angle out, and we start to get this angle here in the neck. This is compensation to allow for air to flow better. So the further back the mandible is, the more we see this type of compensation. If the mandible were fully grown forward where it belongs, this would tuck back up and we'd have a jawline, a distinguished jawline. So interestingly, the perspective here is that the mandible, while it is ahead of this child's maxilla, it's not too far forward. It's still a retruded or retrognathic mandible based on how the neck appears and what kind of breathing and sleeping we have going on. So now this child comes in and bites like this. And of course, in any child, we would have to confirm with speech and some manipulation, where is the lower jaw landing? Is this a forward posture? Is the child jutting their chin out to go here, giving us like an exaggerated smile? Or is that in fact the child's most retruded position in their biting? And in fact, it is. That is the furthest back that child can position their mandible. So here we are growing. The mandible's escaping the maxilla. So the maxilla is not achieving its growth and development. And of course, it has an effect on the mandibular position. So we have an opportunity in the child category, and in this category, we call them removable guidance appliances. And so as we begin to treat children, we have a long list of things that can be used to treat a child. It includes things like nasal attention, so we can help air flow through the nose better. It includes frenum protocols, so we can assess the labial frenum, the lingual frenum, the buccal frenum, to see if those are in fact contributing to restrictions in growth and development. It includes things like getting musculature cooperating appropriately again. Remember, an early hard diet will deliver muscles that are strong and functional to deliver bone growth. So if we already know we're starting with an early soft diet, then our goal would be to work our way towards achieving better muscle function and strength to get the jaw growth back. And there are different, what are called myofunctional guidance appliances that can help deliver changes. So this child using a removable myofunctional guidance appliance can by 5 months' time have an improvement. And at 5 months mark, we already see a big difference in where we are with the jawline and the face. Now that the tongue and the facial muscles have been cooperating or influenced and then producing appropriate strength and function, redirect the bone growth to normal, we start to achieve normal growth and development. The maxilla begins to grow wider and forward. But interesting in the photographs is the change in the neck. So as the lower jaw grows wider and forward, we start to lose the crease and we start to develop the distinct jawline. Now the head and neck are two different structures. As the lower jaw grows forward, the neck begins to rise again. And all of a sudden, this child is experiencing significant maxillary development as well as mandibular release and development forward. So that wider and forward redirection of growth delivers a change in how the child would look in their profile, in their bite. Here we are at 12 months, and that maxilla is growing. Both jaws are growing wider and forward, but the idea is all of a sudden we start to recognize spaces in the teeth. Where we had no space in the lower teeth, we have more space in the lower teeth. All of a sudden, we start to recognize from our photographs that this child is not only growing wider and forward, but the maxilla is outpacing the mandible, both of them going wider and forward to catch up and regain all of our, what we would want to have as ideal normal growth development. So this child, having gone 12 months with certain techniques and appliances, can regain the lost growth and development from that early soft diet. Excuse me. So the idea is, here we are at 12 months where we might have been 3.5 years old at the start. We're 4.5 years old, but all of a sudden our jaw growth is redirected. And what we would have at rest is a very normal lip line, full lip display, an improved bite in the teeth, but the development of the maxilla wider and forward delivers the change in the facial features. So with intervention, we can redirect this child. By the 12-month mark, the child is edge to edge, if not just about over. So something that looked maybe severe or significant enough doesn't have to wait to be treated. The child got in the position they were because of muscle dysfunction. So we call it soft tissue dysfunction. When you have weakness, you have dysfunction. The muscle behaves differently. The jaw growth is different, abnormal, underdeveloped. Meanwhile, if we can regain the proper muscle strength and function, we can redirect the musculature, which will redirect the bone growth and development. So the children that we treat, we begin by 3 as soon as they're ready. And some kids are ready at 3, 3.5, some at 4. Either way, the intervention between 3 and 12 delivers a redirection of the muscles, which delivers the redirection of the jaw growth and development. Now we meet some teenagers too. So in the teenage population, there are similar occurrences because if they were left to their own devices and had the early soft diet and that muscle dysfunction, they would land in a crowded malocclusion. And so here we'll meet someone who has that similar crowded malocclusion, but by the age of 16 also has a TMD symptom list, has sleep disordered breathing. We're going to introduce removable upper expanders in a case like this because we do a fair amount of expander appliances, and expander type appliances can be used at any age. It just has to be the appropriate technique based on the age. We can incorporate, again, our Frenum protocols. This is a patient who will need a Frenum revision. And in a lot of cases, we use clear aligners as well. And so here's a case that has a mixture of expanders and aligners, but as well a Frenum revision. So at 16 years old, this patient ends up at the TMD office to treat her symptoms, which are variable, but include her worst one, which is the weekly headaches. The history that we learn is that the patient had braces for 4 years. Her TMD pain and headaches began during the braces. The jaw clicking and popping starts there also. And the braces are removed just prior to 15 years old. So 11 to 15, this child has braces. And then by 16 years old, this child is visiting the TMD specialist to work on the TMD symptoms. And then we get some photographs. So the TMD expert has some photographs. They send them to us, and we could recognize right here, we've got that crowded malocclusion. And of course, we would know that if these pictures are taken at 16, this is after 4 years in braces. And so the child's had 4 years in braces, and this is their result, and their TMD symptoms are present, including weekly headaches. So when we get involved with treating this patient, we're looking for maxillary development. If we have underdevelopment, then the answer is bigger. We'd like wider and forward. Of course, teeth 7 and 10 are undersized. Tooth 7 is undersized. Tooth 10 is like a microdont or a peg lateral, so to speak. So we have this peg lateral shape. They'll need some bonding. But we have that improper arch form, almost like that V or omega shape arch form. We have a very narrow arch. We're going to begin with expansion appliances. At the age of 19, we have the opportunity to use removable expanders. And so adults at pretty much any age can have removable expansion devices that can deliver growth of the maxilla. And what we get to do here is to increase that maxillary size, change the shape of the vault. And the biggest difference is the distance between teeth 3 and 14. All of a sudden, we have a 10 millimeter expansion here from age 19 to 20. So we deliver an adult removable expansion appliance followed by clear aligners for final alignment of the teeth. So what we have is a lower arch that had begun with some crowded teeth, a little bit of crossbite here. The misalignment delivers malocclusion, and then we end up with full alignment. So the patient has an upper removable expander followed by upper and lower, a set of clear aligners to deliver this result. We did add some bonding to tooth number 7 and tooth number 10, just to bring them up to a proper proportion for the rest of her teeth. So what we're looking at here is the culmination of removable upper expander, clear aligners, composite on tooth 7 and 10, and of course you can see some whitening gel was used while the clear aligners were being worn, so the teeth have a lighter shade. But the only 2 teeth that received dentistry, restorative or cosmetic dentistry, are teeth 7 and 10. The biggest change, of course, it's very visible in the teeth. We tend to lock in the teeth, but we should focus on the foundation. the maxilla is completely different. It is now bigger. Having grown the foundation first and then aligned the teeth delivers a result that is a healthy or ideal occlusion. And that healthy ideal occlusion comes with no symptoms. So our patient who was suffering with TMD symptoms for years, all of a sudden has the opportunity to have a growth and development process delivered that can produce the full growth of that maxilla, allowing the mandible to close where it belongs. The alignment of the teeth produces beautiful function and intercuspation. So we have someone who has more like our typodont occlusion with the full foundation and the tooth placement combined. The patient is asymptomatic. So now we have a happy patient with no symptoms. This patient is now 3 years out of treatment. 3 years, no symptoms, no headaches, everything is gone. The patient wears a clear aligner as a retainer for bed. What was a narrow, underdeveloped jaw structure is now fully developed in beautiful occlusion without symptoms. In this category, we think of this as treating the cause instead of treating the symptoms. Now the patient doesn't have to live with splints or night guards. The patient doesn't have to live with treating the symptoms of the TMD, whereas they could just have the full solution by treating the cause, which is underdevelopment. Well, the techniques also apply to adults. They're just slightly different. So our opportunity to treat from age 3 all the way exists. And again, in the cause category. So we'll find an adult or many adults with malocclusions, many adults with TMD, many adults with sleep disordered breathing. In this case, we're going to utilize clear aligners, but very well could be using adult expansion appliances. The idea is that having malocclusions, having TMD symptoms, having sleep disordered breathing, these are all things that are comorbid or related. So it's not common to find a patient with one symptom. That's more rare to find a patient with one symptom. It's more common to find things related to each other in our patients. So when we take nice histories and we do nice exams, we start learning that our patients exist in multiple categories, and that our research shows there are relationships, or comorbidities is the fancy word for things that kind of run together. So if we meet a patient like this who comes in and we take photographs, we start recognizing that this patient is also struggling. So this patient is suffering with some symptoms, and those symptoms might affect the quality of life. If we get involved, in this case with clear aligners, we can open up that underdeveloped upper arch. So just to pay close attention, he actually has all 32 teeth. This upper arch has 16 teeth in the first photograph. It has 16 teeth in the second photograph. The idea is, what you're seeing here is not an extraction space, it's an opening. The posterior teeth are made wider, the anterior teeth are going forward. We're opening up a space. If we want to open up and develop the upper jaw, all of a sudden we have the opportunity in developing the upper jaw to allow the lower jaw to go where it belongs. Those spaces can be restored. Our choices in restorative dentistry are several. We could place implants there. We could make a traditional bridge, but since the teeth are pristine and have never had any type of dentistry to them, we decided on a fixed ceramic Maryland style bridge just to give him back those 2 teeth that we provided extra room for. So technically this patient has 34 teeth, but in developing the maxillary arch in this fashion and aligning the lower teeth by uprighting the back teeth and spreading out the front teeth forward, all of a sudden it gives us the opportunity to deliver a really healthy bite. The patient began with an edge-to-edge bite and a significant history of TMD symptoms. Narrow and back in the upper jaw has an adverse effect on where the mandible will close. What we saw in the development of the upper arch, wider and forward, produced a space for an entire extra premolar. But what happened to the overjet? Barely any increase. In other words, An edge-to-edge bite where the maxillary development was so significant that we achieved an extra tooth behind the canine. The overjet didn't get crazy. In fact, the lower teeth are aligned beautifully, and here we have just the small amount of overbite and overjet that's necessary for a protected occlusion. As the upper jaw was given wider and forward, the lower jaw released forward. What we end up with, and to keep in mind again in this smile photograph, the only dentistry delivered are the two individual ceramic crowns that exist behind the canines. The rest of these teeth have no porcelain or composite, it's just whitening gel. So when we look at this photograph, the canine to canine area, whitening gel, of course, then we have that extra premolar is my ceramic work. The rest of the teeth are all natural. But the biggest difference is in the maxillary growth and development. So here we have the opportunity to develop that maxilla to allow the lower jaw to land where it belongs and produce a patient that is 100% asymptomatic. The entire history of TMD symptoms fades away during treatment, and this patient is now going on 5 years post-treatment. So the patient who walked in and was struggling is now perfectly healthy with no symptoms, going on their 5th year of only wearing a clear aligner as a retainer to bed. No night guard, no splint, no mandibular advancement device, nasal breathing through the night, and completely asymptomatic. They're no longer a sleep disordered breathing candidate. One of the more significant changes that occurred with the maxillary development for this adult is the difference in the lip positions at rest. At the beginning, this patient was compensating with mouth breathing. The lips were not together very much. The tongue had less space. All of those combinations deliver sleep disordered breathing at a minimum. The moment we get maxillary development and we can have lip seal at rest, it will change the manner in which the breathing can occur through the nose. So with some nasal attention, delivering more space for the tongue, all of a sudden we have that forward and wider development releases the mandible so it can land where it belongs more appropriately, delivering our lip seal at rest. The tongue has more room to live in, so it will migrate forward and higher into the chamber it's given, and you have an easier time breathing well through your nose, which will affect how you're sleeping. So these techniques, whether they're from 3 to any age, do involve collaborative care. And the short list, because this is by no means comprehensive, the short list of the collaborative team involves what's called an orofacial myofunctional therapist or speech-language pathologist. Both are very skilled at working with the muscles of the head and neck, both internal and external, so we can get our muscle strength and balance back. We incorporate ENTs, the ear, nose, and throat doctors, into the equation for our patients to make sure that we have someone with a scope who can look at the contents of the nasal chamber, the septum, the adenoids, the tonsils. What kind of credentials do we have from the nostril through the vocal cord? We want to learn about our obstacles between the nostril and the vocal cord to know, okay, who can help us there too. Oral surgeons, pediatricians, anyone, pediatric dentist, all of the specialties that are involved in from young child to adult can help us with things like frenum revisions, etc. And so whether you're going to a pediatrician in the child category or a primary care physician in an adult, there are different things that we would want to look at from the pediatricians and also the primary care physicians that can help us with our credentials of sleeping and breathing. And then there are others, chiropractors, physical therapists, osteopaths, craniosacral people. All of these specialties have an effect on how well the child can be breathing, posturing, and utilizing their muscle balance to regain growth and development. So across many specialties, we develop a collaborative team so that whether we're dealing with a child, a teen, or an adult, we have all of the opportunities to deliver results like this. One piece of homework I'll give you is to go to YouTube and watch a YouTube video called The Story of Headgear. And so YouTube has on it The Story of Headgear. It's a 6.5-minute video. It begins with this little picture here. When you press play, it'll play the video for you. And what it is, it's basically a public service announcement. It's a 6.5-minute video that was produced by lay people as a public service announcement to teach people that there is a difference between retractive orthodontics and expansive orthodontics. And obviously they're different, they're opposites. But the idea is retractive or subtractive or extractive orthodontics is not the only choice that a child, teen, or adult has. There's an entire field of expansive orthodontic techniques that do exist to grow the jaws wider and forward and align the teeth, which can give the tongue more room and allow for better breathing, which influences the sleeping. So this was put together very nicely, and I would encourage you to go to YouTube and watch The Story of Headgear. And it will give you an enlightening 6.5 minutes, which also cites all of the research that's behind the expansive orthodontics. The website, which is also informative, is www.right2grow.org. And the website provides the research tab with all the articles there. So I would encourage you to watch this video, as well as share it with your friends, family, and colleagues. And it will serve as a very nice informational starting point to recognizing that expansive orthodontics is a wonderful option, and you should really know all and have all your options to think about before choosing a path of treatment. Well, thank you very much for your kind attention. And if you have an interest in learning more, please visit www.airway-health-solutions.com. And you can also find us on Facebook as well. Thank you very much, and I hope to see you at a future meeting.